Hello friends. So in this channel we'll be discussing about the patients that we get in the rounds. So we'll be talking about the most common presentations of most common diseases. At the end of the day we will try to give you the list of the patients that we see and the findings that we find in them, and then discuss a little bit about their etiologies and their management.
Today we saw an echocardiography being done on a patient. Normally the aortic valve looks like the Mercedes-Benz logo, but this patient had a bioprosthetic valve which looks something like this. The next patient we had was a 75-year-old female who is a known case of advanced Parkinsonism. She presented with complaints of cough and fever for the past few days. Her total counts were 12,000. We started her on a combination of antibiotics, clarithromycin, and a combination of ceftriaxone, sulbactam, and EDTA. We also sent an upper respiratory tract biofire, and the biofire report SARS-CoV-2 was positive, so we got the patient isolated. During the rounds, her expressionless faces and infrequent blinking were very obvious. Another patient we had is a 27-year-old female who came with complaints of dysuria and hematuria. The urine routine examination showed 32 pus cells per high power field, and she was diagnosed as a case of complicated UTI. So we started her on piperacillin. The USG report is unremarkable, and we are planning to discharge her once the urine culture report is available. Another patient we had presented with severe pain in abdomen after an alcohol binge. The following differentials were being considered: gastritis, hepatitis, pancreatitis, and acute cholecystitis. The patient was in severe pain and he was not letting us examine him properly. So we gave him IV pantoprazole 40 milligrams and started him on IV fluids 500 ml bolus and then 150 ml per hour. We also charged the IV fluids with tramadol, and eventually his pain subsided. We found that his amylase was 183 and lipase was 1300. Bilirubin levels were normal, so we made a diagnosis of alcoholic pancreatitis.
In order to make a diagnosis of acute pancreatitis, you need these three criteria to be fulfilled. I mean, at least two among these should be fulfilled. The patient should have a severe pain abdomen, and that pain abdomen generally radiates towards the back, and the amylase and lipase levels show more than 3 times elevation, and imaging is also suggestive of pancreatitis. So if you've got any two among these three, then with confidence you can make a diagnosis of acute pancreatitis. A CT scan is not needed to make a diagnosis of acute pancreatitis. So it is done at least 3 days after the onset of pain. Most commonly it is done on day 5 of the onset of pain. In the CT scan we have to differentiate between interstitial pancreatitis and necrotizing pancreatitis. Necrotizing pancreatitis usually refers to the severe form of pancreatitis in which the blood supply of the pancreatic parenchyma has also been cut off. So we do a CT scan and then we look for contrast enhancement. If we don't find any contrast enhancement, we call it necrotizing pancreatitis, and in case contrast enhancement is present, we call it interstitial pancreatitis. In the CT scan, we are also interested in finding local complications. Patients of interstitial pancreatitis can have a non-parenchymal acute pancreatic fluid collection within the first 4 weeks, or a pseudocyst which is formed after 4 weeks. So here the collection is non-parenchymal. Now, patients of necrotizing pancreatitis can have acute necrotic collection or walled off necrosis within the parenchyma or in the peripancreatic necrosed area. Then we have to check if the PaO2 is less than 60 on ABG, or the systolic blood pressure is less than 90, or heart rate is more than 130, or creatinine is more than 2 mg per deciliter. So if we have these findings, then we say that organ failure is also present. Finally, on the basis of local signs and signs of organ failure, we can have 3 grades of severity of pancreatitis. A mild pancreatitis will mean there are no local or systemic complications. Moderate pancreatitis will mean that local or systemic complications are present, but organ failure persists for less than 48 hours. And then we can have severe pancreatitis where organ failure persists for more than 48 hours. So this is all we had for tonight. Good night.